Causal Inference, Bias and Confounding, Part 2, Introduction to Bias and Confounding. The final step in the causal inference process is to convince yourself and others that the observed association is not due to some alternative explanation. Bias refers to any trend in the collection, analysis, interpretation, publication, or review of the data that can lead to conclusions that are systematically different from the truth. The presence of bias affects the internal validity of a study because the observed associations are not due to the causal relationship between exposure and disease, but are due to some other non-causal or confounding factors. The presence of bias interferes with our ability to infer causality and can occur during any point during the process of a study. It can occur during subject selection, information gathering, analysis, or reporting of the results of a study. I'm going to describe three main categories of bias that can occur in epidemiologic research. The first of these is selection bias. Within selection bias, we can have what's called surveillance or detection bias. This occurs when procedures used to select subjects lead to a risk estimate among study subjects different from that obtained from the entire population. This can be caused by differential surveillance, diagnosis, or referral into the study. So if we have a systematically different population included in the study compared to the general population to which we're trying to draw inference, we have selection bias. Selection bias can occur in case control studies or retrospective cohort studies. Another category of selection bias is what's called non-response bias. Non-response bias can occur when you have low participation or differential participation of cases and controls, and it can lead to a bias risk estimate when the likelihood of participation is also related to exposure status. Similar non-response bias can also occur in cohort studies if the likelihood of being included in the study is also related to the likelihood of having the outcome of interest. Another type of non-response bias occurs when there's differential percentages of exposed or unexposed who are lost to follow-up in a cohort study, and this may lead to bias risk estimates if being lost is related to disease status. It's important to remember that this type of non-response bias can even occur in the case of a randomized trial, in which case even randomized trial results can be subject to some bias. Unfortunately, this usually leads to an unpredictable direction of effect on the measure of association, and therefore it's critically important to take all efforts to reduce non-response bias, both in the selection of cases and controls and to ensure complete follow-up in subjects in a cohort study or a randomized trial to minimize the effect of selection bias due to non-response. The next category of bias to be discussed here is information bias. One type of information bias is what's termed interviewer bias, and this arises when there are systematic differences between subject groups in the way information on exposure or disease status are collected. Interviewer bias in terms of exposure status can arise in case control studies or retrospective cohort studies. Information bias related to disease status can occur in retrospective studies, prospective cohorts, or in unmasked randomized control trials. And it can occur when there are differences between subject groups in how information is solicited, recorded, or interpreted. Interviewer bias can affect the accuracy of exposure and disease status, and therefore investigators need to be particularly aware of how information is collected and stored and interpreted to ensure that similar or equivalent strategies are used for all subjects and that there's no systematic differences in the accuracy or collection strategies between cases and controls or exposed and unexposed participants. The presence of interviewer bias can result in erroneous values for risk estimates, which can lead to either overestimates or underestimates of the measure of excess risk. A related form of information bias is the misclassification of exposure or disease status. Such misclassification may be non-differential, meaning that the misclassification is the same for cases and controls, or in exposed and non-exposed, or differential, meaning that the misclassification, for example, of exposure differs based on whether an individual is diseased or non-diseased, or similarly, the misclassification of disease is different for those exposed or not exposed. For example, we would be very concerned if smoking status was recorded with a greater degree of accuracy for those who are cases in a case control study than for controls. There are many sources of exposure misclassification. In a retrospective cohort study, we may rely on old exposure records to assess exposure status. These old records may be inaccurate or incomplete, leading to misclassification. Subjects may also be unaware of their exposure status. In a case control study, we often ask cases and controls about their past exposure. If it was possible that the subject was unaware of their exposure, for example, an environmental exposure, then it may be possible that they don't accurately remember the being exposed. It's also possible that subjects are intentionally dishonest about their past exposure. This is particularly true for sensitive exposures such as sexual risk behavior, and is particularly present in case control studies. The impact of exposure misclassification depends on the nature of the misclassification. If misclassification is non-differential, meaning that cases and controls, or diseased and non-diseased individuals, are equally likely to have their exposure status misclassified, then the bias is generally towards the null value, or a relative risk of 1. So in this case, we underestimate the true association between the exposure and the disease. However, if exposure misclassification is differential, for example, if cases are more likely to have a misclassified exposure status than controls, then we may have an unpredictable direction of bias, leading to either an over or an underestimate of the true association. It's also possible to misclassify disease status. Sources of disease misclassification include inaccurate or incomplete medical records, particularly in the case of retrospective cohort studies where we rely on medical records for ascertaining disease status. It's also possible that the accuracy of diagnostic tests is limited. Some tests have poor sensitivity or poor specificity, meaning that they give inaccurate results in the presence or absence of disease. It's also possible that subjects are unaware of their disease status or are intentionally dishonest about their disease status. As with exposure misclassification, non-differential misclassification of disease generally leads to a bias towards the null, while differential misclassification can lead to unpredictable direction of bias. The final category of bias that I'll discuss here is what's called confounding. As with the other forms of bias, we need to conclude that no alternative explanations by way of confounding exist that would explain the observed association. It's important to consider whether the increase in disease risk we see in the presence of a certain factor is due instead by other co-occurring factors or exposures. We call this situation confounding. Before we can infer a causal relationship, we first must consider the possibility of confounding and either dismiss it or take it into account. We can take confounding into account at either the design or analysis stages of a study. So what is confounding? it's a mixing of effects. If there is confounding, the association that we see between an exposure and a disease is a distortion. This distortion occurs because another factor or exposure that happens along with the one we're interested in is also associated with the disease we're studying. So what we're really seeing is a mixture of the effects of two exposures or factors on the disease. In order for confounding to occur, two things need to happen. First, there needs to be an association between the exposure you're interested in and this extraneous or confounding factor. And second, there needs to be an association between the extraneous factor and the disease you're studying. So let's use an example to illustrate this principle. Down syndrome is a genetic disorder in which an individual has 3 copies of the 21st chromosome instead of the normal 2 copies. An investigator may be interested in whether birth order, or the number of children a woman has had, is associated with the risk of a child being born with Down syndrome. From this graph, we can see a striking increase in the prevalence of births with Down syndrome with increasing birth order. So we have a low prevalence or incidence of Down syndrome among first births, and we have a relatively high incidence of Down syndrome among women who have 6 or more previous births. But we may be concerned here that we have a confounded relationship, and we should think to ourselves, what other factors might be associated both with birth order and with the likelihood that an infant has Down syndrome? These are the conditions that would be necessary in order to have confounding present. So let's review our criteria for confounding. First, we want to look at what our exposure of interest is. In this case, we have birth order. Next, we want to think about our disease outcome that we're interested in this case, Down syndrome. We observe a strong association between birth order and Down syndrome, but we might also be concerned about maternal age. We obviously know that age is associated with birth order. An older woman is more likely to have had more previous births, and therefore we would have an association of higher birth order with higher maternal age. We also know from previous evidence that higher maternal age is associated with the incidence of Down syndrome. So here we see that we have all the conditions necessary to have confounding occurring. So age is a potential confounder of the association between birth order and Down syndrome. This is confirmed when we conduct a stratified analysis in which we construct stratum of age, maternal age, and we look at the prevalence of Down syndrome births within each of these age categories. Confirming our suspicions, we see roughly the same low prevalence of Down syndrome among all stratum of maternal age below 40 years of age, with only modest increase in risk of Down syndrome with increasing age categories in this lower age range, and equal risk of Down syndrome for all birth orders within stratum of age. In contrast to the younger age stratum, among women 40 years old or older at the time of the birth of their child, we see a much higher risk of Down syndrome for all categories of birth order. And within the category of women age 40 years or older, we see that the likelihood of a Down syndrome birth does not depend on birth order. We see roughly the same risk of Down syndrome among women for whom this was their first birth as we do for the women for whom it was their 6th birth. Now let's return to our necessary conditions for confounding to occur. In order for a factor to be a confounder, it must be associated with a disease of interest or with the recognition of that disease. It can be either a cause or a correlate of a cause. The factor also must be associated with the exposure of interest. And finally, the factor cannot be in the causal pathway between exposure and disease. What do we mean by causal pathway? If an exposure determines the presence or level of a presumed confounder, that presumed confounder we would consider to be in the causal pathway. Let's use an example here. If we take smoking as our exposure of interest, and we're interested in looking at infant mortality, we may consider whether low birth weight is a confounder of the relationship between smoking and infant mortality. Now, in this relationship, we would be comfortable saying that smoking causes low birth weight, which in turn puts an infant at higher risk of death. So in this example, low birth weight would be considered on the causal pathway between smoking and infant mortality, and therefore we would not consider low birth weight to be a confounder of the relationship between smoking and infant mortality. We often need to utilize non-epidemiologic or clinical data to determine whether a factor is on a causal pathway. There's no statistical way to distinguish a confounder from a factor that is on a causal pathway, and therefore we need to use our reasoning and outside knowledge to assess whether this pathway occurs. Unfortunately, information may be inconclusive. It may not be possible to definitively determine whether a factor is on the causal pathway or is in fact a confounder. In this case, it may be necessary to consider both the association between the factor of interest and the outcome with and without the potential confounder considered in our adjustment. We'll now walk through an example of how we would go about assessing a confounding relationship between an exposure and a disease. In this example, we'll ask, does drinking coffee increase the risk of myocardial infarction? To do this, we'll construct a case control study of 150 cases and 150 randomly selected controls. From the study, we find that 90 of the cases routinely consumed 1 or more cups of coffee daily in the year before diagnosis. Similarly, we find that 60 controls routinely consumed coffee in the same period. From these data, we can construct a 2x2 table in which the columns indicate disease status, cases or controls, and the rows indicate exposure status, coffee drinking or non-coffee drinking. We can calculate an odds ratio from these data, which yields an odds ratio of 2.25, indicating a relatively strong association between coffee drinking and myocardial infarction. Now, this initial evidence of an association between coffee drinking and myocardial infarction should raise some eyebrows. We don't really have much of a biological mechanism to support this association, and we might think, are there other factors that are non-causal explanations for this observed observation? One that might come to mind would be smoking. So we should ask ourselves, is smoking associated with MI risk? We can address this directly from the data. We can construct a 2x2 table where we have as columns cases and controls, and as rows smoking status. So in the upper left of this table, we have all of the MI cases who are smokers among the non-coffee drinkers, which is 20. In the upper right, we have all of the controls who are smokers and non-coffee drinkers. That would be the unexposed group, and that's 10. In the lower left cell, we have the MI cases who are non-smokers, which is 40. And in the lower right, we have the no MI cases, the controls, who are non-smokers. Based on this table, we can construct an odds ratio. And this yields an odds ratio of 4 for a relationship between smoking and MI. So we see that we have a strong association between smoking and the likelihood of somebody being an MI case. And this is consistent with what we know from other evidence about the relationship between smoking and myocardial infarction. Now we want to determine, is there an association between the factor of interest and our exposure? So is there a relationship between smoking, our potential confounder, and our exposure, coffee drinking? To do this, we look among the controls, those who did not have an MI, and we ask, in a 2x2 table, we look for smokers who were coffee drinkers and non-smokers who were coffee drinkers, and then look how many smokers were non-coffee drinkers and how many non-smokers were non-coffee drinkers. This results in an odds ratio of 16. So we see that we have a very strong association between smoking status and whether or not a person was a coffee drinker. Finally, is the factor our potential confounder in the causal pathway? When we think about coffee drinking and myocardial infarction risk, do we think that coffee drinking causes smoking? I think that's probably pretty unlikely. It's more likely that smoking is related to coffee drinking, either as a cause of coffee drinking or through some other co-pathway, and that smoking also is related to MI risk. So in this case, we don't believe that smoking is on the causal pathway between coffee drinking and MI risk, and so therefore we would consider smoking as an important confounder to adjust for or control for in our analysis of the relationship between coffee drinking and MI risk. In any exposure disease relationship, there are many potential confounders of that relationship. Just because a factor is related to the disease and related to the exposure of interest does not necessarily mean that the exposure-disease relationship will be confounded. Confounding generally only occurs when there's relatively strong associations between the exposure and the potential confounder and between the disease and the potential confounder. Weak associations rarely lead to a degree of confounding of the exposure-disease relationship that would be considered meaningful. We don't judge the presence or absence of confounding based on statistical criteria. Rather, we assess confounding based on our judgment of its effect on the measure of excess risk that we're interested in. One approach is to compare the crude and the stratum-specific measures of effect, and if they differ by an appreciable amount, oftentimes an appreciable amount is judged to be 10% or more, but that's just a general rule of thumb, then we might conclude that confounding occurs and we would need to take measures to adjust or accommodate for the confounding. Similarly, we might compare the crude and the adjusted effect measures and determine if there's a difference between those. Again, a difference of 10% or more might be a good rule of thumb to conclude that confounding is present. But again, remember, it's very important that we do not judge confounding based on a statistical significance test. This is one of the most commonly made errors in epidemiologic research and leads to a great deal of confusion because accurate assessment of confounding needs to be done based on, first, the assessment of whether the basic confounding criteria are met, and second, does the potential confounder actually confound the association, meaning does it have an effect on the measure of risk being studied, not whether it has a significant p-value. So again, let's illustrate this with an example. Returning to our example of coffee drinking and its relationship with myocardial infarction risk, we see that in our crude analysis, comparing cases and controls based on their coffee drinking status, we have a crude odds ratio of 2.25. Now, when we conduct stratum-specific analyses, where we separate smokers from non-smokers, we can conduct two separate odds ratio calculations, first among smokers and then among non-smokers. We see in both cases that we have an odds ratio of 1, indicating no association between coffee drinking and MI status in either smokers or non-smokers. These are what are called the stratum-specific odds ratios. And we see that there's a considerable difference between the stratum-specific odds ratios and the crude value, indicating that there is a confounding of this association by smoking status. Now let's talk a little bit about how we control for confounding. The first type of confounding control can be conducted at the design phase. One of the best strategies here is to conduct a randomized trial. In the process of randomization, we remove associations between exposure and potential confounders. This controls for both known and unknown or unmeasurable confounders, which is why the greatest level of evidence for causal inference comes from randomized trials. If randomization occurs correctly, then we can be confident that all confounders, known and unknown, should be controlled through the process of randomization. However, confounding may still occur due to accidents of randomization. Particularly in relatively small trials, it may be possible that important risk factors for the outcome may be imbalanced between the randomization groups. This didn't happen due to any systematic bias, but it happened just by chance. And the best approach to reducing this risk is to have an increased size for the study and to use stratified randomization methods in which you randomize within the relevant categories of known risk factors for disease. Finally, you can deal with imbalances in factors following randomization in the same way that we would handle such imbalances in an observational study. We'll cover that when we talk about confounding control at the analysis step. Another way to control confounding at the design stage is what's called restriction. When we use restriction, we require all members of the study population to have the same status on potential confounders. This is most useful when potential subjects have the same status on potential confounders. For example, if we were looking at breast cancer, we would probably limit the study subjects to females. While males can develop breast cancer, the overwhelming number of breast cancer cases are among females, and so the inclusion of males would actually make it more difficult to investigate factors that we're interested in their relation to breast cancer risk. Another case might be veterans. Again, most veterans are going to be male, and so restricting our analyses to just males would allow us to have a less confounded relationship. A third example would be neonates. If we are looking at factors associated with birth outcomes, we might restrict our analysis to singleton births, excluding the twin births, which may have different relationships between the exposure and disease and can result in confounding that's going to be difficult to control for at the analysis step. The advantages of restriction are that it enhances our ability to make statistical inferences free of bias. However, it can reduce our generalizability. If we restrict a population in a way that it does not apply to the larger population to which we would want to generalize our results, we're going to have difficulty interpreting our study. It also eliminates our ability to assess effect modification. That would be where we have a different exposure-disease relationship based on some other factor. For example, if we had a different relationship between our exposure of interest and breast cancer among males and females, we would be unable to assess this effect modification if we restrict it only to females. Finally, it may be difficult or expensive to find sufficient subjects if we restrict it in a way that we limit the number of people who would qualify for our study. A final strategy to control confounding at the design stage is what's called matching. In a cohort study, we could match each exposed subject to one or more non-exposed subjects on the potential confounders that we're interested in. Similarly, in a case control study, we might match each case to one or more controls on the potential confounder. So if we had a case who was a male and we believe that gender was a confounding factor, we might match that case to one or more controls who are also male. Another category for which matching is commonly used to control confounding is age. So if we're concerned that age is an important confounder, we may want to make sure that our cases and controls are matched based on age. Matching allows good control for a few well-known strong risk factors. It increases the efficiency, particularly of case control studies. However, it precludes examining the matching factors as risk factors for the outcome, because here we've determined ahead of time what the relationship is between our matching factor and the case control status in a case control study. We may also be concerned if there's differential loss to follow-up that results in imbalance in the matching factors. In this case, the benefit of the matching will be lost if we have differential follow-up. Matching can also create bias in case control studies if your matching factors are actually not related to the outcome that you're studying. Confounding can also be controlled at the analysis phase. We've already discussed conducting stratified analyses, in which we conduct separate analyses based on categories of the confounder. But we can also conduct what's called rate adjustment. We can do this to compare disease or mortality rates between two populations with different distributions of a characteristic, if that characteristic is related to disease or death. Oftentimes we might adjust rates based on age. You may choose to adjust your rates as opposed to conducting stratum-specific analyses when you want to have one single summary measure of excess risk rather than reporting separate measures of excess risk for different stratum of the confounder. Rate adjustment removes the effect of differences based on population composition. You combine the category-specific rates into a single summary value by taking what is essentially a weighted average of each of the stratum. You use an arbitrarily chosen standard population with a known distribution of the characteristic of interest for the category-specific weights. So here's an example. In this situation, we have two hospitals. Hospital A reports 228 deaths in their intensive care unit during 3,200 ICU person days accrued by their patients in a one-year period. Similarly, Hospital B reports 110 ICU deaths in 2,500 ICU person days accrued during the same time period. We might ask ourselves, how does ICU mortality in Hospital B compare to the mortality in Hospital A? We can do this simply by calculating the crude ICU mortality rates. In Hospital A, we see that the crude mortality rate is 71 per 100 person days, and in Hospital B, it's 44 per 1,000 person days. We can calculate the ICU mortality rate ratio comparing Hospital B and Hospital A, and we see that the rate ratio is 0.62, indicating that Hospital B has a lower mortality rate than Hospital A. We can also compare the rate difference by subtracting the rate in Hospital B from the rate in Hospital A, and we find that Hospital B has 27 fewer ICU deaths per 1,000 person days than Hospital A. We conclude from the crude rate ratio that a higher that Hospital B has a higher mortality rate than Hospital A. So we might ask ourselves, is Hospital B's ICU mortality rate better than Hospital A's because Hospital B actually delivers better care, or is it because of some characteristic of Hospital A's patient that would make them more likely to die even if they got good care? This would be an important question to answer if we're comparing the performance of these two hospitals. The relevant factor might be the severity of illness of patients in Hospital A and Hospital B. And we can measure a severity score for all patients and compare the distribution of severity scores between these two hospitals. When we look by category of severity score, going from the lowest category on the left to the highest category on the right, we see that the largest number of hospital days, person days, at Hospital A are accrued by patients with the highest severity score. We see the opposite for Hospital B, in which the highest number of person days are accrued among patients with the lowest severity score. So immediately we have evidence that patients at Hospital A tend to be sicker than patients at Hospital B. So now we decide that we want to standardize or adjust our mortality rates by severity score. We know that there are important differences in the distribution of severity scores among the patients in Hospital A and Hospital B. So what we want to do is choose a standard or reference population with a known or established distribution of the confounding factor. This is step one. Commonly used options for the reference or standard population are one of the two groups to be compared, either Hospital A or Hospital B in this case, or we could choose to combine the two groups into one hypothetical population. We might also take a census population where we have a known distribution of the confounding factor. If we were looking at age as a confounder, this is relatively easy to do, but we probably don't have any kind of an overall census number for what the normal distribution of severity score is in a hospital. So that might not be a good population to choose in this particular case. For this comparison, we decide that the standard population will be the combination of the two populations in terms of their severity score distribution, which is the confounding factor in this analysis. Since we don't have a known ICU severity score distribution for some standard population, for this analysis, we decide that the standard population will be the combination of the two populations, Hospital A and Hospital B, in terms of their severity score distribution, which we are considering the confounding factor in this analysis. We know that in Hospital A, there were 200 person days experienced by those in the lowest severity score category, and in Hospital B, there were 1,500 days in this category. So our combined total is 1,700 person days in the lowest severity score category. Similarly, Hospital A, for the middle severity score category, had 1,000 person days, and Hospital B had 850 for a total of 1,850 total severity score days in the middle category. In the highest severity score category, 2,000 person days were experienced in Hospital A, and in Hospital B, there were 150 for a total of 2,150 hospital days in the highest severity score category. This gives us a total of 5,700 person days of total experience in our hypothetical standard population. In step 2 of rate standardization, we compute the rates in each level of the confounding factor within the exposed group and within the unexposed group, or in this case, within Hospital A and Hospital B. So for Hospital A, in the lowest severity score group, we had 3 deaths in 200 person days, which translates to a mortality rate of 15 per 1,000 person days. In the middle severity score category, we had 25 deaths in 1,000 person days for a rate of 25 per 1,000 person days. And in the highest severity score category, we had 200 deaths in 2,000 person days for a total of 100 per 1,000 person days. We conduct the same set of calculations for Hospital B. When we do this, we can already see that Hospital A actually has a lower mortality rate than Hospital B in the lowest severity score category, and that we see similar patterns for the middle and the highest severity score categories. So we already are seeing that unlike the crude analysis, where we had a higher mortality rate in Hospital A compared to Hospital B, when we look individually, separately, by stratum of severity score, we actually see that Hospital A had a lower mortality rate in each of the stratum of severity score. In the third step of rate standardization, within each level of the confounding factor, we multiply the rates for each hospital by the number of people in the standard population for the exposed group and then for the unexposed group. This gives us the number of expected or hypothetical outcomes if each hospital, Hospital A and Hospital B, had a distribution of the severity score that we have in our standard reference population. So returning to our calculations, we know that in Hospital A, patients in the lower severity score category had a mortality rate of 15 per 1,000 person days. We now pretend that there were 1,700 person days of experience by this group in this hospital. That's the number of person days in our standard population, which is, again, the combination of Hospital A and Hospital B. If this were the case, then there would be 25.5 deaths in Hospital A in the lowest severity score category. Similarly, we know that there were 25 deaths per 1,000 person days experienced in the middle severity score category in Hospital A. If there had been 1,850 person days of experience at this severity score in Hospital A, there would have been 46.3 deaths. Lastly, the actual mortality rate in Hospital A among the highest severity score patients was 100 per 1,000 person days of ICU time. If there had been 2,150 person days of experience in Hospital A at this severity score level, there would have been 215 deaths. We do the same calculations for Hospital B, applying the actual category-specific mortality rates to a hypothetical distribution of person days in that category. This doesn't have to be person time. It could be the number of people instead if we were doing a different type of calculation where we have proportions rather than rates. We've determined a hypothetical number of deaths in each population in each stratum of severity score. Now we sum them across the categories and divide by the total in the standard population. For Hospital A, the expected number of deaths is 286.8, and we divide this by 5,700, which is the number of person days in the standard population, and get a severity score adjusted mortality rate for Hospital A of 50.3 per 1,000 person days. We do the same for Hospital B. Summing the expected number of deaths gives us 562.5 deaths in our hypothetical standard population, and we divide this again by 5,700, the number of person days in the standard population, and we get the severity score adjusted mortality rate for Hospital B of 98.7 per 1,000 person days. This gives us a much different picture than the crude rates. Neither of these rates is an actual rate. Remember that the actual rates were 71.3 for Hospital A and 44 per 1,000 for Hospital B. But when we use this hypothetical standard population, we can calculate a hypothetical rate for hospitals A and B if those rates were applied to a population that had the same distribution of severity score. With this information, we can now calculate an adjusted rate ratio comparing hospital B to hospital A, and this gives us a relative rate of 1.96. So we see that hospital B had nearly double the ICU mortality rate of hospital A, adjusting for severity score. And in terms of the rate difference, for each 1,000 person days spent in the ICU, hospital B had 47.4 deaths in excess of hospital A. So now we need to talk a little bit about when we would use a crude versus a stratum-specific versus a standardized rate. We might choose a crude rate when we want to represent reality. So if we wanted to compare the total mortality rates in hospital A versus hospital B, just to get an understanding of which hospital had the highest death rates, the most appropriate rates to compare would be the crude rates. This would be useful for health service assessments or needs assessments where we simply needed to understand which hospital had the highest death rates without taking into consideration underlying factors such as severity score. We might be interested in stratum-specific rates if we were again interested in representing reality. We truly wanted to know what the rate is in a given hospital for a given severity score, and we wanted detailed information for each stratum so that we could look and see what the distribution of rates was by stratum. This is particularly appropriate when the stratum-specific rates or the rate ratios differ based on which stratum you're talking about. However, this becomes much more complicated because rather than reporting one simple rate or rate ratio, it now becomes necessary to report rates or rate ratios for each stratum separately. Finally, we might consider using standardized rates if we wanted to make comparison with other data easier by using one standard or common reference population for all of our comparisons. This is appropriate when stratum-specific effects are similar, and we want to sum over all of the different stratum to get an overall summary estimate of what the rate is or the relative rates are. In the last segment of this discussion, I wanted to return to our discussion about the guidelines for causal inference. And I wanted to talk in particular about that guideline regarding the specificity of the association. As I mentioned, specificity is oftentimes not considered as an important guideline for assessing causation, and some epidemiologists believe that it should be deleted from the list. However, while we don't need to require that a certain exposure is associated with only one disease, it's still useful to think about specificity in terms of having an association present in certain situations and not in others. And this does aid us in our ability to draw causal inference. If we return to our example of smoking, specificity is obviously not useful as a criteria for assessing the relationship between smoking and lung disease, because we know that smoking has adverse effects on multiple diseases. Smoking increases the risk of lung cancer, bladder cancer, pancreatic cancer, cardiovascular disease, and emphysema, along with many other diseases. So obviously the concept of one exposure, one disease, does not apply in this situation. However, the concept of specificity may remain an important or useful tool when considering causal inference. For example, we may think about the specificity of the exposure with certain exposures being related to the outcome and other similar but different exposures being unrelated, particularly when this is consistent with what's known about the biological mechanism linking the exposure and disease. For example, when we look at whether estrogen, postmenopausal estrogen use, is associated with endometrial cancer, we find that estrogen, when women take estrogen alone, it is associated with the development of endometrial cancer. However, when women take an estrogen plus progesterone regime instead of an estrogen-only regime, we find no association with endometrial cancer. And this is consistent with what's known about the biological effects of estrogen and estrogen plus progesterone on the body in ways that it could produce the development of endometrial cancer. This concept of specificity may be also relevant when we think about susceptibility to disease. For example, when investigating the relationship between the use of certain sulfa drugs and the development of hemolytic anemia, we may focus particularly on people who have what's called a G6PD deficiency. And this is a deficiency in an enzyme that's important in the red blood cell metabolic pathway. And given what we know about the biology of this disorder, we would expect that sulfa drugs would adversely affect these individuals, but would not have an effect on people that don't have this deficiency. Therefore, when we see this association only within this group of people who are believed ahead of time to be susceptible, and not among those who would not be susceptible, this strengthens our conclusion that the relationship between sulfa drug use and hemolytic anemia is in fact a true causal association. Finally, we may think about specificity in terms of outcome. If we think about the question of whether mobile phone use increases the risk of brain cancers or gliomas, we might think about looking at the duration of cell phone use and look at the development of gliomas, but we would consider looking separately at gliomas on the contralateral side, that is the side opposite the side that the person usually holds a cell phone to their head, versus the ipsilateral side, or the same side that they would hold the cell phones to their heads. We would believe that we would be more likely to see an association with gliomas on the same side as the person holds the handset over the contralateral side. And as we would expect, with those who use cell phones for the longest duration of time, 10 years, we see a somewhat elevated risk of a glioma on the ipsilateral side, a relative risk of 1.4, and we see no elevated relative risk for glioma on the contralateral side. So while this is not definitive, it does provide greater confidence that the cell phone usage may actually be causally related to the development of gliomas because of the specificity of the outcome that we observed. So let's review some of the foundational concepts of causation. We should ask ourselves, do we care if an exposure produces disease directly or indirectly? Remember that the earliest definitions of causation really focused on direct causal associations, whether a specific organism caused a specific disease. And that pathway was believed to be a very direct pathway. But we may also think about more indirect pathways that don't involve a necessary or a specific relationship between the cause and the effect. Using the initial definition of causality, a cause is something that if it weren't there, some cases of the disease would not happen. So consider for a moment one causal pathway leading to hepatitis infection in the 1930s. Individuals with syphilis who were treated may have had treatment via intravenous injections. Hepatitis virus may have been transmitted through the use of poor syringe hygiene. So we ask ourselves, was syphilis a cause of hepatitis infection in the 1930s? We might initially think that this doesn't make sense. There's no biological reason why syphilis would cause hepatitis. But when we consider this pathway that involves unsafe injections, then we have to consider that syphilis in this time period actually was an indirect cause of hepatitis. If they had not had syphilis, some of the individuals would not have been infected with hepatitis. So under our broad definition of causation, syphilis would be considered an indirect cause of hepatitis infection. We should also reconsider whether or not a cause must be necessary in order to meet the causal criteria. So we should ask ourselves, in order to be considered a cause, must the exposure have been present in all persons with the disease? When we consider again the case of lung cancer, we can look at lung cancer mortality here among white males who never smoked. And we see that even among non-smokers, we do have some cases of lung cancer mortality. We have at the lower end an incidence of 5 per 100,000 person years among 40 to 49-year-olds, and as high as 40 per 100,000 person years among 70 to 79-year-olds. So in this case, we can say that smoking is not a necessary cause of lung cancer. However, when we plot never smokers against current smokers, we see a dramatic difference in the likelihood that a person will die of lung cancer when we compare the blue line here with the red line. We see that current smokers are considerably more likely to die of lung cancer than never smokers. So we accept that there are some other causes of lung cancer beyond smoking, but we see from these data that smoking is confers a profound increased risk of lung cancer among those who smoke. The third point I want to review in relation to causal inference is the concept of sufficiency. So again, we ask ourselves, in order to be considered a cause, must the exposure be capable of producing the disease on its own? So must a cause be sufficient? In other words, not requiring any other action by other causal factors in order to produce disease. To illustrate the concept that a cause need not be sufficient, meaning doesn't require any other factors in order to produce disease, we can think about looking at the example of gun ownership and the risk of homicide. When investigators looked at 1,860 homicides in 3 counties in the United States, they determined that 24% occurred in the home. They then conducted a case control study in which they looked at 388 cases, which are homes where a homicide occurred, and compared these to 388 control homes and these were homes in the same neighborhoods in which a homicide did not occur. They found that handguns were present in 35.7% of the homes where homicides occurred, and handguns were present in only 23.3% of the homes where homicides did not occur. So we ask ourselves here, are handguns a cause of homicide in households in which a handgun is owned? And we can conclude, I believe, that they are a cause, even though they're not a sufficient cause. Handguns alone don't kill people. People with handguns are responsible for that. But that doesn't make the presence of a handgun in a home not a cause of increased risk of homicide. In some cases of homicide, that homicide would not have occurred if the handgun had been absent. And therefore we must consider guns a cause of homicide in these cases. We've discussed several criteria or guidelines for inferring causality. How do you implement them in judging any one exposure-disease relationship? It's important to remember that this is a subjective and oftentimes gradual process. You arrive at the tentative inference or causal or non-causal determination, but always remain open to the arrival of new data, and be willing to reinterpret your analysis in light of new information. It's also important to remember that these guidelines are not simple checklists. You don't run down the checklist and infer causality once all the checks have been made. You have to apply your judgment and critical thinking when assessing this, and think about your strength of evidence about causation as a gradient rather than an all or nothing conclusion. this concludes our discussion about causal inference and our introduction to bias and confounding.